Welcome to our video on hypersensitivity reactions. Let's get started. In this lecture, we'll cover the high-yield features of hypersensitivity reactions and a particular hypersensitivity reaction called serum sickness-like reaction. Beginning with a general overview of the hypersensitivity reactions, we'll discuss their definition, relevant pathophysiology, and high-yield examples for the USMLE Step 2. Simply put, a hypersensitivity reaction is an unintended immune response that causes disease. There are many examples of this, from simple seasonal allergies to full-blown lupus, and we'll get into these details in a second. In order for these reactions to occur, the immune system must first become sensitized, and this happens following an initial antigen exposure. This allows the immune system to generate antibodies or activate T cells. Once the patient becomes exposed the second time, these antibodies or T cells mount an unintended immune response, resulting in a hypersensitivity reaction. So hypersensitivity occurs following second antigen exposure. There are 4 types of hypersensitivity reactions, which we'll discuss now. This is a table summarizing the 4 types of hypersensitivity reactions. Let's begin by discussing type 1. A type 1 hypersensitivity reaction is an immediate reaction that will occur within minutes after the second exposure to an antigen. In this reaction, free antigens cross-link IgE on presensitized mast cells and basophils, which leads to the release of vasoactive amines, such as histamine, and ultimately culminates in anaphylaxis or atopy. Here's an image to help illustrate the pathophysiology of a type 1 hypersensitivity reaction. Upon second exposure, an antigen binds to the pre-formed IgE antibodies, which in turn bind to IgE receptors on a mast cell. This initiates a signaling cascade within the mast cell, which leads to degranulation and the release of multiple vasoactive agents, such as histamine and tryptase. This entire process subsequently leads to a type 1 hypersensitivity reaction. Notable examples of type 1 hypersensitivity reactions include asthma, seasonal allergies, urticaria, and most notably anaphylaxis, which may occur in response to drug reactions, bee stings, or food. Type 1 hypersensitivity reactions are antibody-mediated reactions, and a clinician may utilize intradermal skin testing to detect specific allergens that initiate this reaction. Here's an image of a technician numbering a baby's back for allergy testing. In this test, various allergens are injected intradermally, and then the site of injection is assessed for swelling. Significant swelling can identify specific allergens, and this information can be helpful in avoiding type 1 hypersensitivity reactions in the future. All right, let's try a question. What is the next best step in management of a patient who presents with anaphylactic shock? All right, anaphylaxis, or anaphylactic shock, is perhaps the most notable and one of the most important tested type 1 hypersensitivity reactions. It's a life-threatening allergic reaction that is generally characterized by upper airway edema and hemodynamic instability, and it must be recognized and addressed promptly to preserve the patient's life. In almost all cases, the next best step in management of anaphylactic shock is to give the patient intramuscular epinephrine. Epinephrine will stimulate the alpha-1 receptors and lead to the reduction of airway edema, increase in blood pressure, and improved organ perfusion. To learn more about the anaphylactic reaction and its management, please refer to our lecture titled Blood Transfusion Reactions from the Hematology Oncology section of our medicine lectures. All right, moving on to type 2 hypersensitivity reactions. These reactions are characterized by IgG or IgM antibodies binding to surface antigens on target cells, which leads to the destruction, inflammation, and dysfunction of affected tissues. That being said, there are some scenarios of type 2 hypersensitivity reactions in which antibodies end up stimulating the target cells rather than marking them for destruction by the immune system. A notable example of this scenario would be Graves' disease, in which the autoantibodies end up stimulating the thyroid gland to secrete more hormones. Here's an image to help illustrate the pathophysiology of a type 2 hypersensitivity reaction. An IgM or IgG antibody binds to a surface antigen, thereby making the cell appear abnormal to the immune system and marking the cell for dysfunction, which can take place via activation of complement or recruitment of natural killer cells. High-yield examples of type 2 hypersensitivity reactions include transfusion reactions, such as ABO incompatibility, hemolytic disease of the newborn, Graves' disease, Goodpasture syndrome, myasthenia gravis, Lambert-Eaton syndrome, and rheumatic fever. Similar to type 1 hypersensitivity reactions, type 2 hypersensitivity reactions are also antibody-mediated reactions. Notably, direct and indirect Coombs tests are often used by clinicians to detect the presence of antibodies that can target and destroy red blood cells via a type 2 hypersensitivity reaction. Students are expected to be able to interpret the results of Coombs testing for the USMLE Step 2. So let's discuss these tests in more detail. This figure illustrates the process of direct and indirect Coombs testing in a stepwise fashion. The direct Coombs test works by detecting autoantibodies that are attached directly to the red blood cells, as can be seen here. The indirect Coombs test, on the other hand, works by detecting autoantibodies that are floating around in the patient's serum, as illustrated here. In general, both versions of the Coombs test evaluate the patient's blood for evidence of a type 2 hypersensitivity reaction. All right, now let's move on to type 3 hypersensitivity reactions. In type 3 hypersensitivity reactions, antigen and antibody form immune complexes, deposit in tissues, and activate complement, thereby leading to inflammation. Here's an image to help illustrate the pathophysiology of type 3 hypersensitivity reactions. As you can see, an antibody and an antigen combine to form an immune complex, which can deposit in various tissues and activate the immune system, leading to inflammation and immune destruction. High-yield examples of type 3 hypersensitivity reactions include lupus, polyarteritis nodosa, rheumatoid arthritis, post-streptococcal glomerulonephritis, and serum sickness-like reaction, which will be discussed in greater detail later in this presentation. Similar to type 1 and type 2 hypersensitivity reactions, type 3 hypersensitivity reactions are also antibody-mediated reactions. In type 4 hypersensitivity reactions, sensitized T cells are stimulated to release pro-inflammatory cytokines and activate macrophages upon encountering an antigen, which leads to a delayed hypersensitivity response. Here's an image to help illustrate the pathophysiology of a type 4 hypersensitivity reaction. A T cell exposed to an antigen uses it to activate a macrophage. Due to involvement of T cells and not antibodies, this process takes a longer time to activate the immune system, which is why type 4 hypersensitivity reactions lead to a delayed response. By the way, though it may have been important to know the receptors involved in this process for Step 1, knowing these receptors is pretty low yield for the USMLE Step 2. High-yield examples of type 4 hypersensitivity reactions include contact dermatitis, as can be the case with exposure to nickel or poison ivy, candida antigen exposure, the purified protein derivative test, and transplant rejection. Once again, type 4 hypersensitivity reactions are T-cell mediated, which means that this is the only type of hypersensitivity that is not antibody mediated. Lastly, because T-cell mediated immune responses take significantly longer than an antibody mediated immune response, type 4 hypersensitivity reactions are also known as delayed type hypersensitivity reactions. Here's an image of poison ivy. Because it may appear so inconspicuous, patients often come in contact with it when hiking or engaging in similar outdoor activities. Contact with poison ivy can lead to contact dermatitis, which we can see on this slide. Note the significant erythema, edema, and multiple vesicles. Remember, this is an example of a type 4 hypersensitivity or delayed hypersensitivity reaction. Hence, a rash like this could take about 4 days or so to develop following contact with an irritant such as poison ivy. All right, let's try a question. What is the treatment for contact dermatitis? All right, pause the video and take a moment to consider this question. Contact dermatitis occurs secondary to immune system activation. Therefore, the treatment should be aimed at suppressing the immune system at the local level. Hence, contact dermatitis can be treated with topical corticosteroids. To learn more about contact dermatitis, please refer to our lecture titled Atopic and Contact Dermatitis in the dermatology section of our medicine lectures. Now let's discuss the serum sickness-like reaction in more detail. We'll go over its definition, etiology, clinical presentation, diagnosis, and management. Let's begin by discussing the definition. Serum sickness-like reaction is a type 3 hypersensitivity reaction that occurs several weeks following exposure to specific antigens. It's similar to true serum sickness reaction in presentation, except it's less severe and its pathophysiology is less clear. Some sources say that serum sickness-like reaction does not involve extensive immune complex deposition like the true serum sickness reaction does. Other sources disagree. The key is to remember the specific antigens that can cause serum sickness-like reaction. Those specific antigens include certain antibiotics, certain vaccines, and acute hepatitis B. Among antibiotics, exposure to beta-lactams such as penicillin or cephalosporins and sulfa drugs such as trimethoprim sulfamethoxazole have been particularly associated with the development of serum sickness-like reaction. Among vaccines, the rabies vaccine in particular has been linked to serum sickness-like reaction in the literature. The clinical features of serum sickness-like reaction usually begin with fever and nonspecific symptoms, such as a headache or myalgias. As the disease progresses, patients may develop a urticarial rash, polyarthralgias, and diffuse lymphadenopathy. Notably, the mucous membranes are typically spared in this condition, meaning that areas like the mouth or the eyes will not be affected. Serum sickness-like reaction is a clinical diagnosis that can be supported with several findings on laboratory evaluation. These include neutropenia, elevated ESR and CRP, low serum complement, and proteinuria. That being said, these laboratory findings are not specific to serum sickness-like reactions and can be seen in other type 3 hypersensitivity reactions as well. Importantly, if the patient develops serum sickness-like reaction in the absence of recent drug administration, the clinician should strongly consider and test for hepatitis B, for example, by ordering a hepatitis panel. The management begins with withdrawal of the offending agent and continues with supportive therapy. Of course, if the reaction was caused by an acute hepatitis B infection, management would involve the treatment of hepatitis B. For particularly severe reactions, clinicians may initiate immunosuppressive therapy with steroids to help the patient get through the illness. All right, let's try a question. A 15-year-old girl returns to clinic with fever, sore throat, and a rash. She was started on amoxicillin yesterday for presumed strep throat. Physical examination is notable for posterior cervical lymphadenopathy and a diffuse rash on the girl's trunk. What is the most likely diagnosis? It may be tempting to consider serum sickness-like reaction because this girl recently received amoxicillin, which is a beta-lactam antibiotic, and now presents with fever, lymphadenopathy, and a diffuse rash. Though serum sickness-like reaction can occur following exposure to a beta-lactam, it's unlikely in this girl because she received amoxicillin just yesterday, which means her symptoms develop only 1 day following exposure. Remember, serum sickness-like reaction usually takes 1 to 3 weeks to develop following exposure to an antigen. Whenever presented with a teenager with a sore throat and posterior cervical lymphadenopathy, the clinician should always consider the possibility of infectious mononucleosis, which is an illness caused by EBV. One of the most high-yield facts to know about this condition is that it sometimes results in the development of a diffuse rash following futile treatment with an aminopenicillin, such as amoxicillin. Hence, this girl's amoxicillin should be discontinued and she should instead be managed with supportive therapy. All right, let's wrap up with a final question. A 31-year-old female presents to her primary care provider due to 2 months of joint pains and general malaise. Past medical history is notable for hypothyroidism and type 1 diabetes mellitus. She takes daily levothyroxine and her insulin is managed by her endocrinologist. She doesn't smoke or drink alcohol. She is married and works as a lawyer. Blood pressure is 125 over 78 millimeters of mercury, pulse is 72 beats per minute, and temperature is 36.8 degrees Celsius. Physical examination is notable for an erythematous rash on her cheeks and mild swelling and tenderness of her metacarpophalangeal joints and knee joints. Laboratory evaluation is notable for a hemoglobin of 10.2 grams per deciliter and elevated anti-nuclear antibody titers. Which of the following mechanisms is most likely responsible for her symptoms? A. IgE-mediated mast cell activation. B. IgG-mediated cytotoxic reaction. C. Immune complex deposition. Or D. T-cell and macrophage activation. All right, the correct answer is C. Immune complex deposition. This female patient has a history of several autoimmune disorders, namely hypothyroidism and type 1 diabetes mellitus, and is now presenting with 2 months of joint pains and general malaise. Her physical examination reveals an erythematous rash on her cheeks and symmetric involvement of her metacarpophalangeal joints and knee joints. This clinical picture, in the context of elevated anti-nuclear antibody or ANA titers, should prompt suspicion of systemic lupus erythematosus as their underlying diagnosis. Recall from this table that lupus is an example of a type 3 hypersensitivity reaction, and that these reactions are characterized by immune complex deposition. This is exactly why option C, immune complex deposition, is the correct answer. Option A, IgE-mediated mast cell activation, is a description of a type 1 hypersensitivity reaction. Option B, IgG-mediated cytotoxic reaction, is a description of a type 2 hypersensitivity reaction. And finally, option D, T-cell and macrophage activation, is characteristic of a type 4 hypersensitivity reaction. So again, the correct answer is C. And that concludes our lecture on hypersensitivity reactions.